our presentation today is not about, it's not a replacement for your doctor's advice or your doctor's treatment. This is all about helping you gain the wisdom, the insights to be able to effectively deal with your condition, ask your doctor more intelligent questions, know how to do in between treatments, or know what to do in between treatments and in between doctor visits. It's all about you taking control of your health while your doctor takes care of your disease. So very, very important. And this quote here I like very, very much. It says this: "I do not believe in a fate that will fall on us no matter what we do. I do believe in a fate that will fall on us if we do nothing." And I assure you that applies to cancer as well as any other disease. There are things you can do. Cancer is not inevitable. And if you do have cancer, death is not inevitable. It doesn't matter how far gone you are, there are things you can do to reverse the tide and bring your health back to what it should be. And so it's also, which, I mean, that's why we are so glad to have people who are qualified to help us on that journey. And Dr. Mead has been on our presentation before, on our webinars before, and he talked about hormones and the importance or the fact that there are things you can do to test your hormonal balance, and he shows you how your hormonal balance can take away from or improve your health. And Sherry is going to introduce him in a minute, but I'm also very, very glad to have Dr. Peter Starr here. Basically, he's a doctor right now because of what he knows. But basically, we have a bona fide movie star on our presentation tonight. And I just watched a movie in which he played a role. So without much further ado, over to you, Sherry, for the introductions.
Okay, sorry, I had to mute and unmute. All right, I will echo David's appreciation for having both Peter Starr and Dr. J. Mead on with us tonight. First, I'll tell you just a little bit about Dr. Mead. He is the President and Medical Director of Labyrinth Clinical Services, and he has been a practicing clinician for over 20 years, and he really does understand the need of getting valuable, accurate, reliable information out into the market. And he is a perfect complement for our guest tonight because of his understanding of alternative medical treatments as well. And he's going to be providing his medical expertise as part of this presentation. Our other guest tonight is Peter Starr, and he has been in the movie industry for decades. He was a movie producer for over 20 years and a stuntman for 10 of those, he says. And then he got into producing records. But about 6 years ago, all of that changed when he personally was faced with having to deal with prostate cancer. And at that point, he started doing massive amounts of research on how he could face it in a more natural manner, and he ended up being taken under the wings of some of the best people in the industry with information on how to fight this naturally, and he's got quite a span of learning there. So everything from being that stuntman and the movie producer to records, all in some ways probably prepared him even for what he is doing today, which is getting information out there to men about facing prostate cancer naturally. I like what David said. He's a man on a mission, and that mission is to help men face up to this disease and be informed of what some of those natural alternatives are. So I'm going to unmute Peter, and we'll hand it over to him. And thank you again for being here.
Thanks, Sherry and David. This is Peter Starr, and what you have on the screen is the logo for our foundation, which is Healing Arts Education Foundation. If you want to find us on the web, you can go to haefoundation.org or healingartsmedia.net. And there's a lot of material on there about the documentary that I've been producing for the last 2.5 years, which is scheduled for release sometime in probably early October, maybe late September if we're really lucky. And that will contain a lot of information, not so much as a how-to cure yourself of prostate cancer or cure prostate cancer naturally, but more of a why-to. Why to take a look at that, and why to really understand the entire cancer process, and also to understand the process of the medical industry, how it works, and why you really have to look at it and become a knowledgeable patient, not a victim of the disease, but in fact someone that is proactive about it and takes part in the control, the management, and the cure of prostate cancer. So having said that, I think if I figure out how to work this system, you should be now seeing prostate cancer, why we get it, what to do about it. And that's pretty been much my goal in life for the last 6 years, not only to find out what I can do personally about prostate cancer, and I'll get a little bit more into that as this develops, but also to pass that information on in an educational manner, because quite honestly, you will not get this kind of information from your conventional urologist, as I've found and as we talk about in the documentary. In fact, some urologists that I've spoken to are very happy that I'm doing this documentary simply because in their role as a doctor, often they cannot prescribe what is good for you. They have to describe what the establishment says you should prescribe. They work within a very strict and guidelines. Sometimes that's not in your best interest. So it's important that you take the reins and work with your doctor or urologist, and at the same time challenge what they have to say and make them challenge why they want to do what they want to do, and to give you the backup and the data and all of the statistics. And they are available. They're just not available conventionally when you go in for treatment. And as one of my doctor friends once told me, he said the problem with general medicine, he said it's like having a hammer, and pretty much soon every patient is a nail, because the hammer is the only tool you've got to work with. And I think that really restricts a lot of things. And as you'll see as this talk goes on, we have an opportunity to expose some of the myths, some of the fallacies of conventional treatment, and to expose you to a little bit to the natural side of healing and taking responsibility for the fact that you've got the disease. And we'll get into that in a little moment. Before we start, what I'd like to do is to bring up another screen here and bring you the trailer for the documentary. Give me a chance to compose myself on where we go from here, and you'll listen and get a lot of information out of this particular trailer. And all of these people you will recognize, I'm sure, because they're quite famous doctors in the realm that we're dealing with. And hopefully I can bring this to full screen, and we'll go. Well, maybe not. What's it about? There we go, into full screen. There we are.
I'll tell you about your father-in-law. He has prostate cancer. I said, yeah, I know. I discovered it 35 years ago when I examined him. He said, you didn't treat him? I said, no, I didn't treat him. He said, good decision. Who likes to get up several times a night and relieve himself because of the incontinency? Who likes to struggle with erectile dysfunction? It's a real problem, and it's embarrassing and humiliating.
We've had an epidemic of prostate cancer diagnosis. We have not had any reduction in overall death rate of prostate cancer according to the treatment.
How much evidence do you need?
There is no way I will ever have a biopsy of my prostate.
You have a little organ the size of a walnut with about 30,000 miles worth of veins and blood running through it. What damage does that do punching 10 holes in it? Mine has never recovered.
To go to the doctor, which is usually the first thought when somebody has a medical condition like this, can only result in being poisoned by drugs, butchered by surgery, and irradiated with radioactive elements. But you cannot undo radiation and chemotherapy and surgery. Those things can't be undone, unfortunately.
Millions of completely unnecessary procedures. I'm looking for treatment. Look at what you've done. I think there is no doubt in my mind that we have done far more harm to men than good.
Of action is to change your behavior. The only real course of action is to change your diet and lifestyle.
You have to be your spouse's advocate, because the doctors are going to tell you their story, and what they tell you may not be what's suitable for you.
If you have cancer, I believe you must become somebody different to get rid of the cancer than you were when you developed the cancer.
The evidence is there that men who want to prevent prostate cancer and men who already have prostate cancer need to make a healthy diet the foundation of the therapy, because you probably know this, the other treatments, they are not good.
Me and my prostate are going to go to the grave together.
Well, there we are. That's the trailer for the documentary that we're producing. I'll bring back up the screen now, and we'll start out. I want to start really with some stats. I don't know why this isn't working. There we go. Let's try this one. I'm not exactly computer literate, but so we're going to be struggling with this, I think, a little bit. Prostate cancer is really epidemic, particularly in Western countries. The United States being very typical of that. Depending on what stats you read, it's anywhere from 200 to 230,000 men are diagnosed each year. Approximately 10% of those will die each year, which basically means that 90% won't. And it's a common phrase that says everybody in America, if they live long enough, will have prostate cancer, and of course most will die with it, not of it. And which is sort of true, but the phrase that's left out of that statement is if you continue to live the Western diet and lifestyle. That's the proviso that one has to make at the end of that statement. But
Peter?
Yes.
Peter? You might have to change this to slideshow view. It's if you click on the third icon from the right at the bottom, very bottom, next to normal view. Yeah.
Yeah. Okay. Can you see that now? All right.
Much better.
Oh, thank you. Sorry. Yeah. Feel free to chirp in because, as I say, I'm not exactly computer literate. We'll work at it. I want to say also that stats vary widely from around the world, and the high incidences of prostate cancer are definitely from Western countries, the highest being Sweden, followed very closely by Norway, and then Switzerland. England is quite a way up there, and these are countries that have high animal fat diets. Back to America, which is we're very much up there. We're like a third at the moment, and we include Canada in that because the Canadian diet is very similar to the American diet, and the Canadian way of life is very similar to the American way of life. There's some very interesting points about the way we live our life here and the diet we eat, and you can compare that with Asia, where men have very low incidence of prostate cancer until they come to America and adopt the American diet and lifestyle. And then they also adopt similar rates of prostate cancer. I was reading about one survey that was done about black men in South Africa. Native South African black men have a very low prostate disease rate on their traditional diets. But when fed a typical American high-fat diet, their testosterone levels fell, their estrogen levels rose, and thus their testosterone to estrogen ratio worsened, and they get more prostate disease. Another interesting statistic is that black men in America have a 30% higher rate of prostate cancer than white men do, or Asian men. And Asian men actually have a lower rate than white men. And again, it seems to be diet and lifestyle that brings that. There's another interesting fact that Japanese men in Japan, whilst might have a similar incidence of prostate cancer, but so few of them die of it. Much, much less of them actually die from the disease when compared to those that die from the disease in America. We can put that down somewhat to the industrialization of Japan and the introduction of some Western habits and Western diet in Japan. But nonetheless, they have a much lower death rate than we do. So there's a lot we can learn from studying those countries. And these are some of the highest rates: Sweden, Switzerland, other Western countries. It is considerably less, by the way, in Italy and Spain, and a little less in France. And again, we put that down to levels of stress and to the diets, the Mediterranean diet being far superior to what we call the standard American diet, or SAD for short. Australia and New Zealand come under the auspices of America in terms of the way they catch cancer and, or rather get cancer. I read the slide differently there. But I might say one thing. You don't catch cancer. It's not something you can catch. It's something that you earn. And I learned that from Dr. Gabriel Cousins, who's one of the proponents of raw food dieting when you come to getting prostate cancer. And I think it's a very important statement. Because, you know, a lot of diseases you do catch. It is spread by viruses or bacteria or common touch. Cancer doesn't work that way. You earn it, you work at it, and that's why you have to work at reversing it to get rid of it. The other thing is cancer is a relatively modern disease, and prostate cancer is typical in that. 100 years ago, whilst cancer was known and we did measure it, it was the last 50 years that we've seen a huge increase in the diagnosis and the incidence and the death rates of a lot of cancers, and prostate cancer, again, is very typical of that. How do we get prostate cancer diagnosed? Well, that's really something now that has come under a lot of fire from a lot of people, because prostate cancer is overdiagnosed. It's probably overdiagnosed to the rate of 40 to 60%. And the way we look at that is that most prostate cancer you don't die from. It's very slow growing. And it's true that you, generally speaking, will die with it rather than of it. There is about a 10% factor in there that is a problem, but is still overtreated and overdiagnosed. And the way that usually starts is people get a PSA measurement. And they go to the doctors, they draw some blood, they send it up to the lab, and they get a PSA. And generally speaking, up until fairly recently, if that was under 4 nanograms per milliliter, generally that was considered normal and nothing was ever done or followed up from that. But the controversy over PSA has really come to the fore in the last year or so, when the man that discovered the PSA, Richard Ablin, in 1970, and the man that made it popular as a diagnostic tool, Dr. Thomas Stamey, who was the head of urology at Stanford in the 1980s, both now say it is grossly misused. And the PSA is actually more related to benign prostatic hyperplasia, which is a non-cancerous condition, the swelling of the prostate, than is cancer itself. PSA is just not a measurement of cancer. It is an indication of inflammation. And to only find out about cancer, one can look at the digital rectal exam, where the physician inserts a finger into the rectum to feel the prostate, and it has a texture about it that is kind of soft and pliable. If it has cancer inside, you can usually feel the tumor or the hardening of the prostate. That's how they decide then to send you if the PSA is high, to the urologist, who then will probably prescribe a biopsy, and we'll talk more about biopsy a little later. Mr. Ablin, who is a professor in Arizona, was quoted recently as saying, "I never dreamed that my discovery 4 decades ago would lead to such a profit-driven public health disaster." And that's pretty scathing commentary from the man that actually discovered it and how he feels it's been misused over the decades to reap in an awful lot of money. In fact, the last statistic I saw, the annual bill for PSA testing and screening, is at least $3 billion, much of that paid for by Medicare and the Veterans Administration because, of course, the age of the patient. The other side of the PSA is the American Cancer Society came out recently to say that they no longer recommend PSA. They think that men should not have it simply because it leads to invasive procedures that really do more harm than good. And so what is happening now is the PSA testing has not gone down as a result of that. In fact, it's stayed pretty much the same. And the reason it has is because of the way that our lawyers operate in this country and the fact that general practitioners have to practice defensive medicine. The point being that the doctor will take your PSA simply to protect his rear end so that he won't get sued. The point being that if you happen to be one of those 8 to 10% that might have an aggressive cancer, and he does not take your PSA and therefore doesn't recommend the following invasive procedures such as biopsy, and you find out 6, 7 years later you've got prostate cancer, guess what? The lawsuits will fly and the doctor will be facing those. One other thing about PSA that most people don't know is that we find PSA in the male ejaculate, the fluid that is made in the seminal vesicles and passes down through the prostate. It's also found in the female ejaculate in concentrations roughly equal to that found in male semen. The PSA is not prostate specific anymore. It never was, of course, we just called it that. In men, the prostate-specific antigen, the protein that it represents, is also made in the male breast. As an example, if you have a serious injury or somebody thumps you really hard in your chest or in the breast, the breast area will make this PSA protein, and it can be measured. The other thing about PSA is it will vary based upon your activity before you actually go and have your blood drawn. If you've had sex the night before, your PSA will definitely be higher. If you've ridden a bicycle immediately before, the PSA will be higher. So it is just not a good indicator of prostate health anymore. I want to hand this over to Dr. J for a second to see if he's got any other incidences or comments about PSA before I move on to my career and what happened to me and how we should move on with the lecture from there. So Dr. J, if you can pick it up and let me know if you've got any thoughts.
Well, thank you, Peter. Yeah, you know, I appreciate your comments, and I think they're all right on. And you know, I hope those listening here take heed to what you've said, even though it is different than what most of us understand, and certainly against what I was taught in medical school and the trends and therapeutic modes that I was exposed to as a young student, and then in my residency, and then eventually in my practice. This is very enlightening, and so I don't have anything other to say than, you know, listen up. Peter's got a lot more to tell you.
Thank you, Dr. J.
My pleasure.
I'd like to tell you, am I back on the air? I assume I'm back on the air. I'd like to tell you a little bit about how I came to this decision to look at natural healing for prostate cancer. I've had a pretty active career, and I've been quite active all my life, except for about 6 years before I was diagnosed. My activity stopped, and I put on a lot of weight around the midriff, and which is not good. It's a high estrogen situation. I became quite stagnant in many ways because my stunt work was no longer called upon. I was getting too old to do stunt work, so I became quite lazy and ate a lot of the wrong foods, and was not the fit person that I've been for most of my life. And Then in 1999, I had a very bad motorcycle accident and was off work and not able to do things for almost a year. And I'll get more into that, into where that plays a role in prostate cancer as we go through the lecture. But I was off work for a long time and became equally less and less active. Until 2004, when I went in for a regular annual physical, and the doctor looked at my PSA, which was 1.2, which it had been for many years. So that was not a factor which would send me to the urologist, except he did a digital rectal exam and found what he thought was a nodule rather, and said, I want you to go see the urologist, and which I did. And I was totally ignorant at that time about what that really entailed. So I went to the urologist, he did a DRE, a digital rectal exam, and said, you know, I don't like the feel of that. We're going to do a biopsy. It was a state where it's not like we should do a biopsy or explain what the biopsy was or its function. He said, we're going to do a biopsy. Well, I knew nothing about that then and submitted to it. And it's not something I'd like to go through again, nor do I intend to. But what the doctor said the following day from the biopsy on the telephone, for a telephone conversation that lasted about 8 seconds, he said, yep, you've got cancer. I want you to read this book and come in and see me, and click, he hung up. And of course, I totally freaked out. And after recovering about 2 days later of my composure, I basically came to the conclusion that I can deal with this and set about learning about what I could do, and that set the journey on the trail along natural health. But I want to say something about the word cancer. And if there are any doctors listening, this is something that I would advise any doctor to deal with in terms of their patients. Instead of freaking people out by saying you've got cancer, why not sort of look at it saying, you've got a tumor in your prostate, and we really should do something about that. We've learned to look at the word cancer as being an immediate death sentence. And it is not an immediate death sentence, nor does it have to be. But we get that. And that then lights the fuse for an immediate run down conventional treatment for immediate radical prostatectomies, radiation, and other radical and invasive procedures, which quite honestly, at that stage, probably are not necessary. And if I've met so many patients that have had radical prostatectomies or brachytherapy or robotic surgery, and I'm telling you, most of the people that I've met, and I've been and talked to in front of a lot of prostate support groups, they will tell you, I wish I'd have known of another way before I did this. Because a lot of these guys today are sitting in diapers, they're impotent, and some of the return of cancer has come back in as little as 3 to 5 years. And we'll get a little bit more into that a little later. So doctors, if you're listening, have a think about the word cancer before you talk to people or frightening them to death with the C word. Now, after the diagnosis, that's when the journey really begins, I guess, because you've become someone that is different. You've become someone that has cancer, and it will turn your life around. It will change your life forever. And people turn to alternative lifestyles, i.e. diet and things, when conventional treatment has failed, and generally that's too late. I have people coming to me asking, well, what can I do? I've had my prostate removed and the cancer's back, or I did radiation and they burnt my bowel and I have rectal incontinence. What can I do? And by then, it's a harder journey than it is to change your lifestyle before you have those treatments. And generally speaking, I think Dr. J will back this up, generally speaking, you have time to research and consider and try alternative lifestyles to see, in fact, whether you can do it and whether it has any success for you. So it's kind of like the now what situation. Now, prevention is certainly the best option, but who's going to change their lifestyle when all seems to be going well? People simply just don't listen to that. People don't make that move, generally speaking, until they've had a swift kick up the rear end and somebody says, you've got cancer, and then it's, oh my God, what do I do now? One of the key issues I found is it's the relationship with your urologist, and it's key to how you view your disease and how you view your treatment. Don't expect your urologist to tell you about other types of treatment, including radiation, including proton therapy, in high flu and those things. Because generally speaking, a urologist is a surgeon, and what they do is cut. That's what they're trained to do. They might give tell you about other types of treatment, but it's generally not what they recommend. So you're going to have to do that research for yourself. And your urologist, of course, remember, is the doctor that will tell you about getting a biopsy. There's a lot of people in my documentary that patients that have said they wish they'd never had a biopsy. And in fact, there's a number of doctors, including Dr. Whitaker that you saw in the trailer, that absolutely firmly says he will never get a biopsy. I can tell you myself, I'll never have another one, because the pay at the end of it does not fit the way that the biopsy works. I'll give you a couple of things. There's a lot of belief, not even belief, but scientific fact in countries like Switzerland, where they've done surveys, in Germany, where they can relate biopsies to the spreading of the disease and basically the upsetting of the cancer within the prostate and bringing the cancer outside of the prostate capsule. So be very careful that you understand what a biopsy does before you submit to having one. The other side of it is dealing with second opinions. Please understand that a urologist generally will send you to another urologist for a second opinion. And that didn't become apparent to me of what that really meant until after I'd done a second opinion. And you realize that it's like two people from the same club. They're educated the same way, they read the same papers, and they will tell you very simply the same thing. And when you want a second opinion, make sure you get one from a diverse situation. And because you need more than what your urologist is going to tell you to really evaluate what is optional for you. And I would go to a radiologist. I would go to people that have done other treatments. I'd go to a holistic doctor, have a chat with them, and find out what they think. Most of this information you can get from other books. One book I'll tell you about is Dr. Larry Clapp, who wrote a book, The Prostate Health in 90 Days, which was the book that was actually my guiding light in the very beginning before I learned other things and started to study it quite seriously. The point is, it is your disease. Taking responsibility for your disease, remember, it's not the doctor's disease, and you cannot expect the doctor to be responsible for the cure or for your survival. To them, you're a patient. If you live or die, you're a patient to them. It is not like what you're going to take it. You're not going to take it as seriously. And as Dr. Gabriel Pessin said, you don't catch cancer, you earn it with your diet and lifestyle. I want to talk a little bit about conventional treatments. Most urologists will take you down the road of surgery, whether it's radical or robotic. The interesting thing is they're finding now that there's very little change, there's very little in the side effects, or as I like to call them, direct effects, when you do radical or conventional surgery. At one time they used to think that robotic or Da Vinci surgery would save you from being impotent, and they'd save you from urinary incontinence and fecal incontinence and so on. They're finding that now that isn't necessarily so. The stats are coming out very, very similar. So if one surgeon wants to do a radical, which is where they cut the abdomen with rather a large cut actually to get in there with their hands, other than the time to recover, which is a lot less with the robotic surgery, the side effects generally tend to come out about the same. Even though they say that nerve-sparing surgery is going to make your chances of being impotent better, in fact, they're finding out now that that isn't just so. It's very, very close. Radiation, you've got brachytherapy, which is where they put seeds in the prostate, and proton beam therapy is where they actually make a body cast for you, and highly focused proton beams are then focused upon the prostate, and hopefully at no other area in the body. They can control the depth that the proton beam activates itself, both on where the beam goes in and where it exits. There are direct effects of that. It sounds very good, and they have, for the most part, probably a better rate of, quote, cure than conventional radiation. But nonetheless, I've seen patients where proton beams have gone right through the colon, and they've had significant fecal incontinence as a result of that. Now, if you've got advanced prostate cancer, it's likely that, or if you've had prostate cancer treatments, surgery or radiation where it's failed and the cancer is back, they're likely to recommend hormonal therapy or chemical castration. And this is where they give you a drug such as Lupron or flutamide or Casodex. And what it does, it cuts off the testosterone in the belief that testosterone is the problem. Well, the side effects or direct effects from that kind of treatment is that it will reduce your muscularity, it will reduce the density in your bones, and your bones shrink, your muscles shrink, and guess what? Your heart shrinks and you die of a heart attack. And that's a real big issue. I've talked to men that have died, I talked to them obviously before they died, where they've had that treatment and they've ended up having cardiac arrest and they died. And I believe, and a lot of other doctors believe, that they would have had a better chance of survival had they not had their testosterone cut off through chemical castration. Now remember that in the very beginning, 60 years ago, they used to physically castrate men because, again, they thought that testosterone was a problem. We now know differently, and we now know that estrogen is the problem, and estrogen dominance in men is the problem, not testosterone. We'll get into that a little more, and Dr. J is going to talk a little more about that because it's linked highly also to adult onset diabetes. Now, I want to talk about chemotherapy real quickly because chemotherapy is generally not used with prostate cancer, even if the prostate cancer is metastasized, because generally it goes to the bones, and generally speaking, chemotherapy is only given as a palliative, not in any way to arrest the disease or even as a potential cure. Now, there's been some changes in that recently, and it's called insulin potentiation therapy. It's a therapy that was started in Europe, but now you can get in the United States. It is FDA approved, but it's generally not available on Medicare or on insurance because it is fairly new, and they haven't sort of got the track record yet. But simply what happens is by adding insulin to take the patient into a closer level of what you might call insulin coma, it helps the chemotherapy get into the cancer cells and kill the cancer cells. And then they give you a dose of glucose to bring you back to normal. It's about a 40-minute treatment. The point being is there is almost zero side effects. And you can feel very good coming out of the treatment, which if you've ever had or know anybody that's had chemotherapy, it's very hard to look at chemotherapy and think the patient is coming out feeling better than when he went in. There's two of the kinds of treatments that are generally offered, and that's cryosurgery or cryotherapy, where they freeze the prostate to kill the cancer cells, or HIFU, or high-intensity focused ultrasound, and there is a hyperthermia treatment as well, which is done somewhat in Germany. All of these are fairly new, don't have a long track record. My personal experience is that with cryosurgery or cryotherapy, you have a very high rate, about 100% rate of impotence. HIFU or high-intensity focused ultrasound, I've seen patients that have had that done where it has not worked. It is quite expensive. It's generally not covered by Medicare or by insurance, and that'll cost you about $20,000 to $25,000. And I've yet to see a good rate of cure for that, and I've seen several patients where it's just simply not worked. Now, the risk of side effects, surgery, any surgery poses a major risk. The risk of removing the prostate range from death to urinary incontinence, impotence, and if you're ready for this one, a reduction in penis size that I've seen up to 2 inches. And you tell men that, and they go, boy, I've got to research that a little better before anybody gets in there and cuts out my prostate. And in my documentary, I've actually interviewed men where that has happened, and one man said he took a look at his penis and said, it's no good to man the beast. And I'll leave the rest up to you on that, but be aware that that does in fact exist. Death rate from surgery in a review of 10,600 cases was 2%. Damage to the heart, there's something we don't read about very much, 8%. 6% of these men will require the use of pads because of incontinence, and a higher percentage will have a urinary dribbling. Not quite total incontinence, but nonetheless quite annoying. 60% of men will be impotent after surgery, and this is with the so-called nerve-sparing surgery. And again, that's very similar in robotic surgery as well as open prostate surgery. The statistics are conservative compared to the results of a survey that Medicare patients underwent, and that was over 30% required urinary pads. 63% reported some problem with urinary incontinence, and this has continued. This doesn't go away. It means spending a great deal of your life with walking around with Depends. And 60% reported impotence, and 90% of those could have erections, but reported they were not sufficient for vaginal intercourse. Something you really want to think about before you go down that road and discuss it with your wife. If sex is still important to you in your marriage, take a real good look at this. One thing that I don't hear very much talked about is fecal incontinence. And this is a lot higher than I'd even learned about when I started studying this. And it can be as high as 32%. Particularly with nerve-sparing surgery, I understand, as compared to a standard surgery, which is around 17%. Radiation, the side effects for that, again, are very, very high, and not as much as initially as surgery, but it seems to build, particularly in the incontinence side. Again, something you really need to learn about and look at before you agree to any kind of radiation. Now, we know that radiation causes cancer, and this is very, very obvious in a lot of other cancers, such as like Merkel cell carcinoma, where the evidence is very high that it's caused by radiation. We don't find that the causation for prostate cancer is in radiation, but take a look at other statistics, take a look at what other doctors say before you make that decision. Be well informed. Hormone therapy, as I said before, they cut off your testosterone, and typical side effects include impotence, almost 100%, hot flashes, a loss of sex drive, almost 100%, diarrhea, nausea, and liver toxicity, and again, the penile shrinkage up to 2 inches. And something again very seriously to look at and to rate the importance of the treatment versus your lifestyle after treatment. At this time, it would seem that there's very little justification for the use of invasive and toxic methods of the treatment of prostate cancer. A lot of doctors will tell you different things, but remember, as I said, doctors, their treatment is all they've got, and generally speaking, they don't look at the disease in a holistic way. And I believe that people should look at cancer in a holistic way, and don't just sort of assume that the hammer that the doctor has is going to hit the nail that you've got and make it go away. Let's dwell for a moment on watchful waiting. I really don't think very much of watchful waiting, simply because who in his right mind would just stand there and wait and watch? I truly believe the only approach to curing prostate cancer, treating it or managing it, is not inactive watchful waiting, but being proactive and do something to change one's diet and lifestyle, certainly before you have conventional treatment, to see if that's something that you want to do and see if in fact you have the discipline to change your life and change the way you think and change the way you look at medicine. I want to talk about how to understand natural healing. The way I look at it is there's really 3 issues involved. It's things that your body is deficient in, which generally comes down to food, which can be looked at in terms of curing it with food supplements, better diet, not eating as much animal fat, certainly cutting out milk, looking at the toxics that are in your food, specifically when it comes to milk, because milk is really not the raw milk that we remember 50, 60 years ago. Milk is almost a chemical concoction these days, and they have to add things like vitamin D3 under the assumption you're not getting vitamin D3 and vitamin A and so on. It's probably better to get those food supplements without getting any milk. Milk also has things like bovine growth hormone, which is designed to grow a calf from a small animal to a 3,000-pound cow, something that I personally don't think I need in my body. And the second thing about the diet is really the way we look at our hormones. And I'm going to call upon Dr. J in a moment to address the issue of hormone testing and addressing the relationship of estrogen and testosterone and progesterone and so on. Dr. J is one of the leading authorities in this country and features very heavily in my documentary about that, so I'm going to defer to him shortly. The second thing I look at is what is toxic in the body. As far as prostate cancer, we're concerned with things like mercury, cadmium, lead, and nickel in the heavy metal category. And we test by using a fecal testing. We test the what comes out the other end in terms of what your body is passing through with those. Particularly with mercury, we look at, because we know that most of the mercury we get in our bodies doesn't come from fish, although some of it does. It comes from amalgam fillings in your mouth. And some dentists have been saying this for many years, but we're going to deal with that when I get to the dental section. And the third component is what we call the emotional component, which deals with stress, emotional traumas, the way we live our life. And my personal belief now, after studying this whole thing for 6 years, is you have to treat all three. You cannot deal with two of them and let the emotional component go, because you're not dealing with what the body is dealing with. And we bury those emotional components in the cells of our body, and they live there. We need to get rid of them to help the chemical side, to help the hormonal side, and help detoxify the body to make it that way. It's important in having a functional blood analysis to find out what's going on in your body. Take a look at what's going on there. Deal with a doctor that has a holistic view and can tell you what's going on in your body. I also believe we need an amino acid analysis, because amino acids are the basis of the proteins that make up our immune system. If your amino acids are all topsy-turvy, you're not making the proteins that your immune system needs to attack the diseases and the pathogens and the viruses and the bacteria that's running around in your body. And so we send people for both of those analyses before we take a look at what to do about their disease. Now we're getting to the hormonal side, and Dr. J, if you're there, I'd like to bring you in at this point and let you take over the lecture to talk about what we have found and what we need to do in terms of the relationship to testosterone and estrogen.
Yeah, very well, Peter. Thank you. We'll get my slides set up here, and we'll speak to that. Actually, while that is happening, I would like to reinforce what Peter said. Number one, about the waiting. Once the diagnosis is made, there certainly is no need to panic. I know a lot of folks do, and I understand that because the C word is such an emotional component in our culture. But we all know, those of us in the pathology world where I train, is that this is a very slow-growing tumor, and as Peter mentioned, 90% of us will, even with the diagnosis, will not die of the condition. So there's plenty of time to ponder, to get different opinions, and as Peter mentioned, get another opinion from outside of the model that you've already been working in. You really need to know what the breadth of choices are for you with this condition and this situation. Now I will open up here with some slides that start out with some humor, although sadly humorous. In medical training, and certainly in my medical training, and I don't think this has changed much since the pharmaceutical industry basically controls our medical education in this country, is that preventive medicine kills return business, and that was not mentioned directly, but that's a subtlety there. And for those of us who have branched out, and as I did later in my career, to look at preventive medicine, it's absolutely amazing what you can do before and even after a condition is diagnosed, such as prostate cancer. You've already seen a photo of me. I'll pass on that. I do want to mention, and I'll leave this up for a moment, that my primary business right now is working with testing saliva, and I'll speak more to that through the slide presentation. And I started a company called Labrix, and this is information that you can use to contact me or my marketing assistant, Tori Hartkey, and we will be glad to share with you my slides for this presentation or tell you more about saliva testing and how that can help. Now, one of the myths that we would like to dispel during this presentation is that testosterone therapy does not increase the risk of prostate cancer. And there are a number of studies, and this is a very good review article, and I have a quote here from that article, which is very similar to what I'm going to show you on the next slide, so I won't read that quote, but this is from October 2008, and this is a review of 27 articles, and they basically concluded that that's a myth, and they support that with the evidence in their review article. Now, here are a couple of articles I would like to share with you. I mean, this in the first article, they actually took young men and injected them with testosterone. So they took healthy young men and they gave them even more testosterone than they made to see what would happen with their PSA levels or their prostate gland volumes, and there was no change. And you know, in one of the very simple concepts that we overlook in this whole discussion about testosterone is that males 20 years of age have normal-sized prostates and they don't have prostate cancer. There's no risk of prostate cancer in that age group. I mean, it's pretty simple logic, isn't it? And well, in this study, they actually took males and injected them and again showed no change in their prostate volume. In the next paper, they actually showed that there was a higher prevalence of biopsy detectable prostate cancer in men identified with low total or free testosterone levels, despite normal PSA levels. And I think Peter has done a good job of debunking the PSA test. It's flawed. It has a number of pitfalls and a lot of misinformation surrounding it. Now, I will speak more to this because this is a topic that's near and dear to my heart. But the diseases associated with low testosterone in males are 80% of the time the cause of our death, other than cancer, and that is type 2 diabetes. Now, in this study by Hammerstein, they actually made that connection between hypertension, the prevalence of type 2 diabetes, and a more lethal form of prostate cancer. And I will tell you that males, as we age, lose testosterone. So again, it's not the young men with high testosterone levels who get prostate cancer. It's the older males who have a dropping testosterone level. And that dropping testosterone level is associated with type 2 diabetes, or what we call, is commonly known as metabolic syndrome. Now, in that group of metabolic syndrome patients, in a study of middle-aged Norwegian men followed for 27 years, that actually predicts a greater cancer risk. So again, low testosterone is associated with a disease and a risk for prostate cancer. So if testosterone doesn't cause prostate cancer, what does? Well, Dr. John Lee, made a connection in the early 70s about breast cancer in women, and noted that these women had excess estrogen relative to their progesterone levels. And what happens in women over time, and it's similar in men, is that their estrogen levels, even after they've stopped ovulating, continue, while their progesterone level, because that can only be made in the ovary, declines. So where do they get estrogen? And they get it from the same place men do. We convert our testosterone, we males, and females convert their testosterone to estradiol, the highly potent and carcinogenic estrogen. So as we age, men and women, our estrogen levels go up. Dr. Lee coined the term estrogen dominance, and he believed, and I certainly do, and I think there's plenty of evidence to support this, that it's estrogen dominance in males, not testosterone, estrogen excess, relative to progesterone, that leads us down the path to enlarged prostates, benign prostatic hypertrophy, which is a precursor to tumors or cancer in the prostate gland. He wrote a monograph, which I would recommend to any male looking at this seriously. Hormone Balance for Men, what your doctor may not tell you about prostate health and natural hormone supplementation. And the point that he makes, and this is very important to understand, is that during our development as embryos, we all start out as females. And then when the Y chromosome kicks in the male fetus, the male genitals then develop. The prostate gland is the same has the same embryologic origin as the uterus in the female. So we know that the uterus is hormone sensitive. I mean that's so obvious that none of us would be here if it weren't. Then that the prostate has the same capacity to be affected by estrogen. Now, what does estrogen do to our prostate glands when it's not opposed by sufficient progesterone? It makes our prostate glands grow. So that leads into benign prostatic hypertrophy, and then eventually, unabated, that can develop into cancer or a tumor. Now, Dr. Lee observed in the females that he treated with progesterone that they had a decreased risk of breast cancer and uterine cancer and ovarian cancer and osteoporosis and a number of other conditions. And he followed them and he monitored their progesterone to estradiol ratio. And that's a very important ratio to have tested for all of us facing this risk. And that ratio is best obtained through saliva, and we will speak more about that as we go. And the antidote to a low progesterone to estradiol ratio is to give progesterone. Now, progesterone is a natural hormone to the human. We call it bioidentical. So it's a bioidentical hormone that is readily available. It's not of pharmaceutical interest because it is a natural occurring hormone. So we will not find a progesterone cream available from a pharmaceutical company. However, it is readily available through a number of other sources, and if you would like to contact us, we can help you understand where that is available to you. Compounding pharmacists make it. It is readily available. Now, I have a number of slides, and I'm not going to go through all of them, or we will be here for quite a while. But I am going to hit some of the highlights. And what I would like to show you here as an adjunct to what Peter has told you is that it's now understood, becoming more understood by the population anyway, that low testosterone puts us at risk, males at risk, not just for prostate cancer, but from death. So this was actually an ABC news release where they looked at 800 men aged 50 to 91 living in California, and there was a 33% greater risk of death over the next 18 years with a low testosterone level. Now, this is a low total testosterone level, which the total testosterone measurement is flawed, but nonetheless, that was what they used. Now, they also go on to say at levels not quite that low, men have decreases in their libido, erectile dysfunction, fatigue, physiologic changes. Many will not immediately recognize. And for those of you listening in, tonight we are trying to raise your awareness. There are physiologic changes that happen to males when their testosterone level starts to drop, and their erectile dysfunction is the least of their concerns. There are changes in our physiology which will lead to chronic debilitating disease and death. Now, I also want to mention, and Peter's touched on this, that the conventional medical model is confused, I'll kindly say, about this. And Dr. Finkelstein was interviewed by the ABC News, and he or she says no one knows what low really is. So in response to this study, Dr. Finkelstein is not really sure about what's going on there. He actually goes on to say, I certainly will not change my practice. I see it more as a challenge to the scientific community to determine if low testosterone really is the cause of increased death, and if so, how that occurs. Now, I would say you'd have to live under a rock to not appreciate what low testosterone does to males in our culture. Now, here's an interesting case. This is actually one of my patients. This is a 63-year-old male who has had a diagnosis of prostate cancer. He had a prostatectomy, actually against my better judgment, I thought. But he went the conventional route for his prostatectomy. And Peter's given you some alternatives to that, and you know, I certainly support what Peter has said about that. Those are all right-on concepts. I will also mention that, and Peter didn't mention this, and he didn't mention it because it's not available in this country, but there is a form of hyperthermia, increased heat, that works very well in the prostate. And simply what happens is the catheters push through the penile urethra up to the prostate gland, and the prostate gland is heated slightly above basal temperature, and the cancer cells are more susceptible to the heat exposure than the normal cells, so the cancer cells die, the normal cells survive, and there's a cancer cure. This is commonly done in Europe, in particular in Germany, and I've seen the studies coming out of at least one of the German clinics that shows that hyperthermia is as effective as radiation therapy or surgery. And it leaves the male completely intact, no nerve damage, no proctitis, and certainly no change in the ejaculate, etc. I mean, it's pretty amazing, an amazing form of therapy. So, and again, that's something that we can help you with. If you want some more information on that, we can direct you to those sources. So back to my patient, the 63-year-old male. So he had gone 12 months with PSAs less than 0.3. So even by conventional wisdom, in quotes, that low PSA means that he's cured. His chief complaint to me was erectile dysfunction, but I can tell you his blood sugars were high. He's pre-diabetic. So that was my main concern once we addressed that. He went to his urologist because he wanted his urologist to buy in to some testosterone therapy for him. He had read enough to know that low testosterone was not only the cause of his ED, although there was probably some nerve damage from his prostatectomy as well, but also one of the causes of his high blood sugar. So he literally hounded his urologist, and eventually his urologist wrote him a letter, and this is a quote from the letter. The letter was addressed to my patient. However, it's obviously it's for me to read and appreciate. And I'll read it with you. Unfortunately, I did warn him that androgen replacement therapy may result in a euphoric syndrome that would make him feel like he is doing better when in reality he is not really obtaining any significant improvement. we have discussed this at length and actually spent over an hour covering these issues, and hopefully he has been provided with enough information to proceed in an intelligent fashion. And I would say that the patient did indeed proceed in intelligent fashion. He came back to me. He's on testosterone. His ED is resolving. His blood sugars are coming down. He's feeling better. His lean body mass is going up. So all of the benefits of testosterone are happening to him, and he's continuing his therapy, and I suspect will continue it until he is no longer vertical. Now, some of this is redundant, and so if you don't mind here, I'm just going to pop down here. I want to show you. I want to hit some of the more important aspects of this presentation. Here's a comic of David prior to his visit to the United States and then 2 years later. So it goes without saying that in our culture, we have a tendency to obesity. In fact, it's an epidemic. And the point to make here is that this visceral fat, excuse me, this visceral fat, this truncal fat and the fat in the thighs and upper legs here, is the most insulin-resistant fat we have in our body. So when that develops, when we become obese in this area, when we start collecting fat here, and it doesn't have to be as large as what we see here on David after 2 years in the United States, but as soon as the waist size starts going up, our visceral fat is increasing, and we are now becoming insulin resistant. What do I mean by that? I mean that it takes more insulin to manage our blood sugars than it did before we had that much fat. And then as that fat develops, the need for insulin continues to go up. And the pancreas is an organ that can only produce so much insulin over our lifetimes. And eventually we wear the pancreas out. And then we become a diabetic and we need insulin. But prior to becoming a full-fledged diabetic, we are labeled as insulin resistant, or we have the metabolic syndrome, which means our blood sugars are steadily going up because our insulin cannot keep up with the situation, and we have high blood sugars, and the consequences of high blood sugars are pretty amazing. Not to dwell on this too much, but just to mention that the reason that fat tissue takes our testosterone and converts, that's the other component, I beg your pardon, that adipose tissue, again in the trunk, not only is the most insulin resistant tissue in our body, but it also contains an enzyme called aromatase. And as we have more fat, we have more aromatase. This enzyme converts our testosterone to estradiol. So we've got a couple of things going on here. Our blood sugars are going high and our estradiol levels are going up. And as mentioned, that puts us at risk for prostate cancer. Now I'm going to go through these slides because they're somewhat redundant. So we develop insulin resistance and we then develop diabetes, and that first sign of insulin resistance, if we could address that and manage that in a preventative way, we will reduce 80% of all non-cancerous disease in our culture. The consequences of not dealing with that are diabetes, obesity, and eventually heart disease and death. Women have less issues around cardiovascular disease than men, and one of those reasons is, again, our testosterone going down. Now, I mentioned that diabetes has consequences. I apologize if this slide may offend some, But this is really what happens to us once we develop adult onset diabetes. Adult onset diabetes is a tragic disease and it is preventable.
Dr. J?
Yes.
Could you go back to that, the graph? I know you zipped past it, but that looked pretty interesting. Can you talk a little bit about that, please?
About this graph?
Yes.
Yes. Sex hormone binding globulin, or SHBG, is an estrogen amplifier. And one of the phenomena that happens to us physiologically, we males, physiologically, is that as we age, our SHBG levels tend to go up on this axis. It's a phenomena of aging. Now, SHBG preferentially binds androgens, and within that category of androgens, we have testosterone, and of course, then DHEA. But testosterone is the primary androgen that we're referring to here. So SHBG preferentially binds testosterone at 98% and estrogen at 90%. So when we're young, we have a low level of SHBG, not binding our testosterone. Again, as we age, showing this axis here, our SHBG levels go up. So what happens then is that our testosterone levels on this line right here fall, and as the testosterone then binds to the SHBG as it increases, we release estrogen. So not only are we generating estrogen from the adipose tissue or the fat in our trunks, but we are also generating it because the SHBG, or sex hormone binding globulin, goes up as we age. Did that answer your question, Dave?
Yes, it did. Thank you very much.
Thank you. You're welcome. So the point is that young men have low levels of SHBG, they have high testosterone, and testosterone is good for our health. And men with disease states like diabetes and aging have lower serum levels of testosterone and higher levels of sex hormone binding globulin, which decreases the bioavailable testosterone. And that's why, as I mentioned earlier, the total testosterone measurement is flawed. If you don't know what your sex hormone binding globulin level is, you don't really know what your bioavailable testosterone is. That's if you're measuring serum. If we measure in saliva, we actually have a free testosterone level. It's very simple to do, and I'll mention that here as we go along. Now, before I get to that, I'm reflecting back on what Dr. Finkelstein said about that study that was released, the ABC report that I showed you early on. Since 1939, doctors in Europe have realized that other than insulin, testosterone improves glucose control better than any pharmaceutical drug on the market in the world today. And that is still true, even though this was written in 1987. Here's a paper. This actually was a paper from the peer-reviewed U.S. literature from 1996 in the Journal of Diabetes. Quotes, data from intervention studies suggests that low secretion of testosterone may be a primary event in the pathogenesis of insulin resistance because the replacement of testosterone to normal values reverts insulin resistance. And I have a very interesting patient. He's a current patient of mine. His sex hormone binding globulin was 120. Now, to put that in perspective, 50 is considered high. He had 120. I didn't believe it. I thought there was a lab error. I repeated it, and it came back again at 120. And I've measured it another time or two as we've treated him. And his sex hormone binding globulin is almost 2.5 times the high level as reported by most laboratories. So his total testosterone was within range, and it's actually in the upper part of the range. And so his conventional doctor didn't go any further with that, and he told him he had a normal testosterone level. Well, his blood sugars were creeping up, and he had a friend who was a patient of mine, and his friend talked him into coming to see me. And as I worked him up and I found his SHBG level to be so high, we did some saliva testing, we also did some serum testing, and indeed he had a low bioavailable testosterone level, or free testosterone level, if you will. His blood sugars were in the high 90s when we started treating him. Within 30 days on testosterone, his blood sugars were down to 70. Now, he wasn't a diabetic, but he was heading there, and he has no worries about being there now. He was also losing muscle mass, gaining some weight around his middle, losing some sexual desire and sexual function, and now all of that has returned. Now, just so you know that Peter and I are not out on the periphery here in La La Land and making this up. There are paper after paper available actually showing these phenomena. Now, a lot of these papers come from Europe. In Europe, the Europeans tend to be ahead of the U.S. I think most of us are aware that in longevity, out of all the industrialized countries, we are at the bottom of the industrialized nations, whereas we're at the top on spending money on healthcare. But we spend money at the end of life instead of spending money on preventive medicine. So the reason we're at the bottom is because we don't think about preventing diseases. We want to treat it once it's occurred, and we unleash all this fancy technology at that stage of a life instead of preventing the disease. So the Europeans are ahead of us on here, but we are starting to see papers coming into our literature now. Here's an article from 2009. Just so you know that this is currently still at the fore for some individuals. This is an article from the Frontiers of Hormone Research. Testosterone levels are reduced in obesity, the metabolic syndrome, and type 2 diabetes. Low testosterone levels are now being recognized as an independent risk factor for these conditions. Findings from men undergoing androgen suppression. Now this is, Peter mentioned androgen suppression, or Lupron, or there are a couple other pharmaceutical drugs that will suppress the brain from producing the hormones that stimulate the testicles to make testosterone. And so this study actually looked at the findings of men undergoing the androgen suppression in the treatment for prostate cancer, confirmed that the hypogonadal state now created by the Lupron, or whatever drug it may be, that hypogonadal state increases body fat mass and serum insulin, and there is a high rate of developing new diabetes in this population. In addition to what Peter told you about losing muscle mass. In fact, I had a patient who came to me from California because nobody in California would treat him. He'd been on Lupron for 5 years, and he could not stand on one foot. He was losing balance. He was, and he had no muscle mass. He had no drive. He had a burned out feeling. Of course, he had erectile dysfunction, and his blood sugars were going up. And so I started him on testosterone, and that was over 6 years ago, and he's doing very well. And his wife writes me that she's appreciative of having her husband back. And so the drugs that are used for the chemical castration. Now, this man didn't have metastatic prostate cancer. He had localized prostate cancer. Yet his practitioners put him on such a toxic drug, a drug that so altered his physiology that was going to kill him long before prostate cancer might have, and there was no evidence that he had prostate cancer anyway at that stage. Testosterone has other benefits. Of course, everyone knows about that. Erectile dysfunction improves, and that's because testosterone improves, reduces penile venous leakage. Here's an article that's very interesting. This was actually in the Journal of American Medical Association, so this is a peer-reviewed, well-respected journal. And in this article, they actually reported that they looked at the brains of individuals with Alzheimer's disease, and there was a significantly lower testosterone level in those in that tissue than in the matched controls. So testosterone affects our cognitive function, affects our brain health as well. It increases nitrous oxide synthetase, which is going to be good for our hearts. Now, I'll pass through this, but I do want to touch now on ways to test. You can measure serum, and I mentioned, having, a need for that sex hormone binding globulin. So if you measure the total testosterone level, divide it by the sex hormone binding globulin value, multiply it by a factor needed to convert the sex hormone binding globulin from nanomoles to nanograms, you get a free androgen index. Now this is used in Europe regularly, and I use it in my practice now if I do measure serum, which I don't have to measure because I have this other tool. The salivary gland is an amazing organ. It blocks, if you will, it's a sieve. None of the proteins, sex hormone binding globulin is not crossed there, across those membranes. We're actually getting a pure, if you will, steroid sample. And a steroid is a category of hormones that includes the estrogens and testosterone and DHEA and cortisol and progesterone, etc. So you can actually use saliva to measure your free, unbound, or otherwise stated bioavailable hormone levels. Of course, it's stress-free, stress-free, and also very cost-effective. There are a number of studies that have validated using testosterone for diagnosing hypogonadism and then also for monitoring the therapy. And what I suggest physicians test, and this is what I do in my practice, I measure the estradiol levels and progesterone levels. Remember we talked about the progesterone to estradiol ratio. That's important. And progesterone for males to maintain prostate health is very important. And I have a whole presentation just on progesterone. In fact, I presented that on this webinar a few weeks back about the benefits of progesterone to our hearts and our brains and our bones and our prostates. I would measure testosterone, of course. If I'm going to measure serum, I measure SHBG. Now, I do measure PSAs because, as Peter mentioned, there is a certain amount of need to do conventional testing. But I understand what PSA means, and I use it mainly to monitor my patients with cancer. So if that PSA started to go up in a cancer patient, I would be concerned in undergoing testosterone therapy, for example. So I would then stop therapy and evaluate that. So I do measure PSA levels. Measuring lipids, very important, particularly the triglycerides. That component of the lipid test is very important to pay attention to because the triglycerides tend to go up when one is becoming insulin resistant. Measuring fasting blood sugars are important, of course, and measuring insulin levels, at least initially when we start approaching therapy. Now, it's very important also to measure the complete blood count, the CBC. And the reason we want to do that is to make sure that the red blood cell component of the cellular component of our blood does not get too high. And one of the consequences of testosterone therapy, if it's not managed carefully, is that the red blood cell component can increase and make our blood too thick. So we want to monitor the CBC level. Now, treatment, I want to reinforce, we want to manage with hormones, and that's a component of what we can do and how we can manage our wellness. But good nutrition is absolutely essential. In fact, that's foundational. what Peter said about, you having control over the course of your life and your condition or your cancer, whatever it is, and hopefully you don't get to the cancer stage, but if you stop and think about what you're doing with your health and how important it is, hopefully it can help you change your paradigm. In fact, a good friend of mine, a peer that I respect, has in his office a quote on the wall from an anonymous source, and it says, if you don't take care of your body, where else are you going to live? And that kind of brings the point home that we really are responsible for our wellness, and good nutrition is the foundation for that. Now, when my patients want a resource for that, I tell them to read the China Study by T. Colin Campbell. There are a number of books out there that are quite good. I found his book to be excellent. It was a 10-year prospective study done in China, and the conclusions are profound in that book. In summary, what he says is to eat a plant-based, whole food, low-fat diet. And I believe that there are a number of experts, including those on Peter's in Peter's film, that support that concept. Plant-based, whole food, low fat. Another quote I heard from another author is, eat food, not so much, mainly veggies. I mean, these changes don't have to be earth-shattering. You can make these changes gradually, but you need to change your lifestyle if you're drifting in the wrong direction. Regular exercise is important, and of course hormone balancing, as I've mentioned. Americans are twice as fat as Europeans. Reaction, well, the American actually bites the hand and eats the microphone of the individual. So here's the nutrition. Here's the actually the citation for T. Colin Campbell's book. I'll leave that on for a moment in case you want to write that down. Excellent book. Mine is so dog-eared it's about ready to fall apart. Avoid such foods. Peter mentioned milk. I mean, cow's milk is for little cows. It's actually unhealthy for humans. It has more phosphate than it does calcium, and that calcium to phosphate ratio is critical to the human. And when we drink milk and we get that extra phosphate, we actually leach calcium from our bones and waste it. So if you've noticed, the dairy industry doesn't say everybody needs milk anymore, because that's not true. They say milk has calcium, and then they also say that osteoporosis is a mineral deficiency. You're supposed to make in your mind the connection between milk and osteoporosis, when in fact drinking milk, drinking any carbonated beverage actually changes that phosphate ratio for us, and we lose calcium from our bones. Not to mention the animal protein in there, which changes our physiology, changes our pH, and puts us at risk for cancer. You got to read the China Study. Avoid white sugar, white flour, and white rice. The four whites. Very simple concept here. I mentioned waist circumference is critical. That is even more critical than measuring your BMI or body mass index. Huge study here that showed as soon as that waist starts to expand, problems start to develop. Now, just so you're aware of how testosterone treatment should occur, first off, there is no oral form of testosterone that is not toxic. So oral therapy is not an option. Intramuscular injections are an option. Transdermal creams are an option, and I use both of those in my practice. Some males don't like to inject. Some males don't mind injecting and prefer that. Some males don't like cream on their body, and some do. Either of those modes are very effective. Subcutaneous pellets are available. It's not something I use in my practice, but those are available just for completeness sake. These are pellets of hormones that are placed in the subcutaneous tissue, usually in the lower flank and the back, and they stay there for several months and slowly release hormone. It's a surgical procedure to place those and replace them. I won't go into the dosages and so forth. That's not really within the scope of this, and we're running out of time here. We may want to take some questions. But in my clinical practice, my philosophy is to use the lowest dose of any hormone or any substance, even if it's a supplement, to achieve the clinical response. One can overdose even on a good thing. And I see this frequently, particularly with a product that came out initially, a topical product for hormone testosterone replacement called Androgel. Had a very high dose, and the doctors using it were monitoring serum. And unfortunately, you can't use serum to monitor a topically applied hormone. You can use saliva, and the dosages on initially were way too high. And consequences, as I mentioned, your blood thickens. I also should mention the testicles shrink, and so there are consequences to pay attention to. Here they are: smaller testicles, aggressive behavior, reduced sperm counts. Testosterone is a contraceptive for the male, and so I counsel all my males about these risks. Erythrocytosis is a fancy word for the thickening of the blood. Again, this is how you can contact either Tori or myself. And with that, I will pause and open it up for questions.
Okay, well, great. Thank you, Dr. J. I'm not sure if Peter still has any more slides to show or pictures to show.
Can you hear me, David?
Yes, I can.
Actually, I do. There's a couple more subjects I'd like to touch on, and my question to you is, how much time do I have?
You go ahead. We want to see it. So I'll just hand you. Are you ready for me to hand it over to you?
Yes.
Okay, go ahead.
The first thing I'd like to, I was actually prepared with some film clips, including some clips with Dr. J on the issue of testosterone, and also about Dr. Morgenthaler, who is the professor of urology at Harvard, who actually really threw the testosterone thing for a loop amongst conventional doctors by showing that the basis of their treatments, which has been going on for 60 years, was in fact totally wrong. And I did interview Dr. Morgenthaler on that very issue. I don't think we have really time for that clip, but there's some things about testosterone, about prostate cancer that I would like to touch on, and one is vitamin D3. I did interview Dr. John Cannell, who I believe is one of the leading authorities on D3, and I'd like to show a clip of him in just a second. But what made that interesting to me is that the rate of prostate cancer increases as the latitude gets higher. In other words, the less sunshine you get, the higher rate of prostate cancer. People who live in Boston, for instance, have a higher prostate cancer rate than do people who live in Hawaii. And that's pretty significant as far as the doctors that I've talked to that have followed this. When I talked to Dr. Cannell, I said to him, well, if you were diagnosed with prostate cancer, what would you do? And he said, well, the first thing I'd do is I'd be taking 10,000 units of vitamin D3. And that was a pretty interesting comment for him to make. And I'd like to just run this film clip of him now. It's about 3 minutes long, that deals with vitamin D3. Then I've got a few more statistics before I move on to the next stage, which is really the emotional side of this issue. So if you're ready, I'll click on that now, and we'll see if we can make this a full screen.
Was involved in prostate cancer. It occurred 20, 30 years ago when the Garland brothers and Gorham and some others discovered that there's a latitudinal variation to prostate cancer. If you're a man and you live in Hawaii, your chances of getting prostate cancer are significantly less, 2 or 3-fold less than if you live in Boston. If you're a man living in Florida, your chances of getting prostate cancer are much less than somebody living in Wisconsin. Nobody knew why. I mean, there were a lot of theories about why there was this latitudinal variation in prostate cancer, and no one knew why. And vitamin D is a precursor to an extremely potent steroid hormonal system. This system, which is quite complicated, evolved in man and most other animals a long time ago, and it's based upon, predicated upon sun exposure. When the sun strikes your skin, it photoisomerizes a pre-vitamin D molecule, a cholesterol type of molecule to make the vitamin D. This is a repair and maintenance steroid hormone. That's what it does. It repairs and maintains the cell in many, many ways. When a cell thinks about becoming cancerous, it develops certain properties. One of the properties is it loses what's called apoptosis. Apoptosis is what cells are supposed to do. They're supposed to die and be replaced. When you think about cancer cells, they don't do that. They live forever. That's why they kill you. They don't die. Vitamin D forces normal apoptosis. The other thing that vitamin D does is it promotes what's called differentiation. All the cells in your body need to know what they're supposed to be. Prostate cells need to know that they're prostate cells, and heart cells need to know they're heart cells. But cancer cells are often what we call poorly differentiated. They don't know what they're supposed to be. And the more poorly differentiated the tumor, the more aggressive the tumor usually is. Vitamin D promotes differentiation. It also prevents what's called angioneogenesis. When the tumor starts growing in your body, it hijacks your blood supply. It has to get its own blood supply, so it hijacks yours. Vitamin D helps prevent that. So in many ways, the steroid hormone is almost the perfect anti-neoplastic agent, the perfect cancer drug. If you decide to get your sunshine in a bottle instead of the way nature designed for it, you're taking a risk. This is a risk. We know that sunshine does one good thing. It makes vitamin D. Well, what does sunshine do that we don't know? We don't know what it does. We don't know. Nobody can know what they don't know. Well, this is a complex system, and your skin is a complex organ. And it may well be that sunshine does something else that's very important to the human body, and we just don't know it. So if you decide to get your sunshine in a bottle, you are committing hubris. You're saying arrogantly, I know all the stuff that sunshine does. I don't need the sun god. I'm going to take it in a bottle and forget the sun god. Well, the Greeks knew that the gods don't like that kind of stuff. So you're taking a risk. The most conservative thing to do is to make sure you get sunshine when the sunshine is available. That's a conservative thing to do because you're close to the natural system. And then only take the vitamin D in a pill form when you have to because you don't have any sunshine available or you, for some reason, can't get out in the sun.
Well, that's a little statement on vitamin D from Dr. John Cannell. There was a lot of other stuff that I was going to touch on, but I think it's probably time to really go into the into what I call unresolved emotional trauma. This is something that generally in America it's ignored. It is much better understood and practiced in Germany and Switzerland, which is where I actually started doing most of the interviews that I did to come together with this information. I have yet to meet, there's only one urologist I met in the United States so far that understands this unresolved emotional trauma aspect and does in fact practice emotional medicine as part of his protocols. In Germany in particular, they have a medicine called German New Medicine that's pretty much designed to isolate what traumas are really being held in your body and resolving them. There's another system called Psy-K, which is an American, which is actually an American, I won't say an invention, so I can't think of a different word right this minute, that was developed by Rob Williams and Dr. Bruce Lipton. Dr. Bruce Lipton has become quite famous of late through a book called The Biology of Belief, which I absolutely recommend people reading. If you don't like reading books, he has a very good DVD on the subject, which is a lot easier to actually ingest and retain. But what I will say is that, as Buddha once said, holding on to anger is like holding on to a hot coal with the intent of throwing it at someone else. You're the one that gets burnt. And with that, I'll tell you a quick story about a patient. We at the foundation here actually coach men in natural healing with prostate cancer, and I don't like to call them patients because I'm not a doctor, but I'll call them a client. And one of the clients that we had approach us had so much open anger in his system towards us because his doctor had given him conventional treatment that had failed, and the cancer was back, and the doctor basically said, well, there's nothing else we can do. There's nothing we can do. Go home, prepare to die. And so he called us, and the first thing that was happening was he unloaded this anger on me, that he called out for help, which I found really interesting. We've now in the process of resolving that anger through both Psyche and German New Medicine, and we don't have the total resolution yet. The patient is, or the client is still dealing with it, but we fully expect that he will come out of this once the emotional traumas have been dealt with. The other thing I want to touch base on is diseases of the mouth, because certainly in Switzerland, they will not treat cancer at holistic clinics, particularly Dr. Thomas Rao at Paracelsus, before you have your mouth dealt with. And in fact, they have one of the most up-to-date dental clinics that I've seen anywhere at the Paracelsus Clinic in Switzerland. And because their science and their data shows a direct relationship between diseases of the mouth, the gums, the mercury in amalgam fillings, and root canals being directly related to chronic disease, particularly prostate and breast cancers. And one statistic that Dr. Rao quoted to me was that in 300 female patients with breast cancer, 97% had root canals on the teeth that directly related to the meridian that related to the specific breast, be it right or left, and they thought it was a direct relationship, whereas 150 women with no breast disease, only 33% had root canal problems or problems of the gums on that particular energy meridian line. But 97% that had breast cancer had bad teeth on those, and mainly root canals. In Australia, and again in Switzerland and Germany and Austria, there's been studies that deal with the mercury toxicity. And in the particular study in Australia showed that prostate cancer tissue had anywhere from 30 to 300 times the mercury in the diseased prostate tissue than in healthy prostate tissue. And the line, you'll have to take my word for this at the moment, that that comes from the amalgams in your teeth primarily. Not totally, but primarily. And we show in the documentary a direct connection with that, with some animation of mercury vapor coming off diseased teeth and amalgam fillings that have outlived their usefulness.
Peter?
Yes.
I just want to remind you to make this a full screen so we can see the whole slide. And also, I just want to let you know to not feel rushed. Take all the time you need to take. We really want you and Dr. J to give this the best treatment you possibly can. So.
Okay, well, I'm almost to the end of the, I've got one more piece of video I'd like to show, and I'm almost at the, unfortunately I don't know how to do this any other way, but this is how I don't, this is the last slide actually, and I'll read it to you. And it comes down to the fact of why are we not told? Back in 1992, that's a long time ago, almost 20 years ago, a study in the Journal of American Medical Association showed about 223 patients concluded that no treatment at all for prostate cancer actually was better than any standard chemotherapy, radiation, or surgical procedure. Why aren't we told this? We're not told it when we go to the urologist. We're not told it when we go to the oncologist, and we're certainly not told it when we go to a radiologist. And I think we need this information to make an honest-to-God treatment or choice of treatments. And as I say to people that I talk to, no treatment comes with a guarantee of success. And the choice, as always, is yours. I would like to finish up with one more piece of a video before we take questions. If I can just bear with me a second while I pull this through. This is on the issues of diet, and there's so much data and so many studies on diet that just the one that Dr. J talks about, or several he talks about, there's so much more that need to be read by people with prostate cancer before they choose whatever treatment they decide to choose. And there is no judgment here. We tell patients it's yours. Whatever treatment is, it's your choice. And take responsibility for the disease and the treatment because it very much is your life. I'm just going to start this and make it into a full screen. And here we go.
Not only from prostate cancer, but from virtually all causes.
I think the biggest factor that affects our abilities to heal ourselves is emotional issues and how they're held in and processed by the body. If you get those emotional issues cleared up, it will unleash a fountain of healing energy that'll help you mentally, that'll help you spiritually, that'll help your immune system, and that'll just help you heal better, quicker, no matter what else is going on with your prostate cancer.
Thought is everything. Okay, 30% of the population dies within 2 weeks of their birthday because they put in their head, I'll never get past 70, I'll never get past 80. So, you know, that's what they put in. When a doctor tells you got 6 months to live, he's now sentenced you, bam, put the power right in there. And now you're through in 6 months.
A man who has got a positive attitude and wants to fight the disease, whether he's taking allopathy or homeopathy or any system of medicine, that fighting spirit is going to help him. He's going to definitely make a recovery better than a person who's totally negative and with a sense of resignation, let us say, and then unwilling to fight the disease.
Even the hyper-conservative CDC has acknowledged that 85% of all illness has an emotional component. And it's probably more than that. It's probably even closer to 100%.
The mind is a phenomenal medicine in itself. And it's never to be discounted, ever, in any kind of healing.
If you have a set of beliefs that you can beat a disease, that you're not a victim of that disease, but you're the actual master of your own destiny, and you can influence your biochemistry by your beliefs and understand the science behind that, then absolutely you can influence that. That's like using your mind as medicine. That's one of the most powerful medical interventions on the planet and one of the least understood by the medical profession.
The body is actually a communication mechanism, and it's always expressing how we feel emotionally. And if we're holding on to traumas, which we all have trauma, either in our memory or our DNA, I believe that trauma is the master cause of all degenerative disease. And so even though we can physically manipulate and reverse a condition like prostate cancer by the physical things that I've talked about, I believe that for a long-term solution, we still need to address the fundamental cause, which is the traumas that we hold at the cellular level, which causes us to continue to react to the circumstances of our daily lives according to our expectations. In fact, I would say that expectation is the greatest trap in our lives, because if life beat us up before, our expectation is it's going to beat us up today and tomorrow. And if it doesn't beat us up, guess who gets stuck with the job? We do it ourselves.
Well, that's escaped from that. That's my presentation as far as I've got time to now. And I'll throw it back to you, David, to see what you want to get back to questions and answers.
Absolutely. Well, thank you so much, Peter and Dr. J. Yes, we still...
Jay, I'm sorry, there's just one more thing I might say, that the documentary that we're producing and that will be finished in perhaps a couple of months actually is a 2-disc set. There's so much data and so much information encompassing the entire realm of prostate disease and prostate cancer and how to deal with it in a natural way. that there's only just a fraction of it been presented here tonight. Over to you, David.
All right, thank you. Thank you again, Peter and Dr. J. Please stand by, because I'm sure there are lots of questions that are going to be coming in. And while that is happening, folks, just remember you can type in your questions in the chat box at the top right of your screen. In front of you is a wonderful lady by the name of Jackie Harvey, who, by the way, is responsible for, in an interesting way, the webinar we have tonight. Jackie actually introduced us to Dr. J, who has, like he mentioned, done a presentation for us. And Jackie has done quite a few for us as well. I mean, she has learned a lot from doctors, worked with several doctors, including Dr. J. As a matter of fact, she does a lot of the testings. Her and her consultants do the testing. So if you want to find out your hormonal balance and whether your testosterone levels, as Peter and Dr. J have mentioned, she is the one to contact. And she can send them, help you get the samples to show you what you need to do, and send them to Dr. J's lab to have them tested. And that's our website up there, helpforhormones.com. And her mission is to help the hormonally challenged. Big mission, I tell you that right now. Okay, I'm just going to do a few more infomercials while the questions are coming in. Dr. Harry will be on every Monday. This Monday he won't be in, but we're going to be providing a recording. He focuses on heart disease and what you can do about it. Bernie Siegel, you just watched this last video presentation by Peter about the emotional and psychological component. Well, Bernie Siegel has been shouting about this since the early 70s, and he has been a pioneer in that. He's going to come and talk to us specifically about that, what you can do as a person if you have cancer of any kind, and how you can win that quote-unquote battle within. So please be sure to be on it. Mark Waldman did a presentation on Tuesday called Think and Grow Thin. He and his partner, Dr. Newberg, the two leading researchers in the whole field of psychology, spirituality, and the brain. And they have a lot of imaging studies, done a lot of imaging studies to show people what happens in their brains when they think negative thoughts, or when they think positive thoughts, or when they pray, or when they read, and how their attitude towards food is. So you really want to be in on that. It'll be available only till Saturday, so you want to jump in and watch that. Okay, just want to mention again, we probably mentioned it at the beginning, these webinars, the live webinars, are free to everyone, absolutely free. Just come, as long as you have a computer or even a phone, just come in. Now, they are free, but they don't come cheap at all. I have to mention that it's just the software itself, it's over $1,000 just to have the software, not to mention the blood, sweat, and in Sherry's case, tears that go into making this production. And so some people have actually mentioned that, well, why don't you just get donations? We are always welcome to donations, and if you feel like you feel moved to send something in, that's great. But these webinars will continue no matter what. There is a membership section, and I'm pointing at it right now, and I think for a fee you can actually have access to over 150 presentations that we have had in the past. They are all available online, and I tell you, if you've enjoyed today's, I mean, this probably stands out as one of the best, but there are several other wonderful presentations that you can watch and access, and this is all towards helping you improve your health and helping you and your family take control of your health, and knowledge is where it has to begin. So please go to our website and take a look. It's buildingstrengthwebinars.com. Okay, I think I've done enough of my commercials. Dr. J, you have access to the questions, don't you?
David, can you hear me? It's Peter.
Yes, I can hear you.
I just wanted to say one other thing real quick that I forgot to mention. We talked a little bit about a healthy mouth, and one of the teachers that I learned from about that was Dr. Harold Rabins, that's R-A-B-I-N-S, here in Los Angeles, who's been a leading spokesperson for holistic dentistry for over 35 years. Mm-hmm. And his website, ravcoholistic.com, has a chart you can download to learn about the connection between the meridians of the body and each of the teeth. and it's free, and you'll learn an awful lot about what's going on in your mouth and the relationship to chronic disease from that.
That's a very interesting point. Could you repeat the website again?
Yes, it's Ravco, spelled R-A-V-E-C-O, holistic. That's all one word, ravcoholistic.com.
Great, thank you. And as a matter of fact, we've had a few presentations by a very well-known dentist, according to Cambridge, is one of the top 2,000 healthcare professionals in the world. He did a presentation specifically on mercury toxicity in the mouth and how that affects your brain, cancer, and your cardiovascular system. So I can totally relate to what Peter is talking about.
Oh, it's again, so much of this is underrated in terms of treatment, and Dr. Rao will not treat anybody for cancer until they've treated their mouth first. I think that speaks volumes.
Wow. And this is an MD or an ND?
Oh, yeah, Dr. Rao is not only an MD, but he's a professor at the University in Switzerland in medicine, has a clinic called Paracelsus, and he treats patients from around the world with a high level of success, and it's totally holistic.
Wow. Impressive. Impressive. Okay, Dr. J, have you been having access to the questions? You want to go ahead?
I do. Can you hear me?
Yes.
Okay, great. Well, first of all, I want to reinforce again the wonderful information that Peter's been sharing with you on. He mentioned vitamin D. Absolutely, that's essential. Having sufficient levels of vitamin D for our wellness and cancer prevention. I would also mention to add to that list is iodine. Iodine deficiency is very common in our culture, and there are ways to measure iodine levels, and sufficient iodine is essential also for prostate health. And that all comes back to what we put in our mouths, and in some cases the food we eat may not be sufficient in certain minerals and elements, so that we have to then supplement them.
Dr. J, can I interrupt just for a second?
Certainly.
When you talk about vitamin D3, there's actually a recent study from Germany about vitamin K2.
Yes.
I didn't get a chance to mention, where they had a huge study that shows that K2, men taking the highest amounts of vitamin K2 had about a 50% less prostate cancer. And K2 is also instrumental in the absorption of vitamin D3.
Yes. Yeah, that's very new information, and it's I think it's very valuable. What I have read is pretty convincing, although it is very fresh information. But I think that's on the floor of wellness, folks who look into those sorts of things. So vitamin K2 is definitely worth considering. Now I have questions. I don't know if Peter has access to these.
I don't see anything. I don't even know where to look to see them.
Okay, I think maybe I have those. I'll start at the top here. One question: what do you consider a dangerous PSA level in active surveillance? PSA levels, as Peter mentioned, are fraught with variabilities and flaws. So in my practice, because I do have a medical license in several states and want to keep those, I use the parameters that the laboratory provides me. So a PSA greater than 4 is a high PSA, and I, not being a urologist, will refer a patient to a urologist who has a high PSA and let the urologist evaluate them. So PSA levels vary up to several hundred, and I think a PSA of several hundred would certainly be something to be concerned about.
Can I make a comment on that?
Certainly.
Dr. J? I had a PSA of 1.2 when I was diagnosed with cancer, and I've seen clients with PSAs in the low 20s have no cancer at all.
Yes.
And it is far too many people get a high PSA or a higher PSA and then get biopsied and have problems following the biopsy, and when there's no cancer at all. So my recommendation is, before you consider a biopsy, you might want to consider a 3D Doppler ultrasound And if that shows nothing, then I would not have a biopsy. And,
absolutely, yeah.
That's what they do in Europe. They've now do not recommend biopsies in certain countries in Europe for that very reason. They have this high-powered 3D Doppler ultrasound, and it seems to be working well for those over there.
Then I'll move on to the next question or comment. Please have Dr. Mead again put up the slide showing where to access his saliva test. Actually, the slide I showed, I appreciate how that could be misleading, is ways to contact me. We don't sell or service the public directly from the laboratory here. We only work through providers, and Dr. David has shown you Jackie Harvey here. In fact, she's up on the screen again. Help for Hormones is a way to access the saliva testing if you'd like to do that. Next question is erectile dysfunction an indication of prostate disease? Interesting question, and the answer is yes, indirectly, most likely. Because if an individual is starting to experience erectile dysfunction, the testosterone level is falling and the estradiol levels are going up, as I showed. And as estradiol levels go up, the prostate gland tends to enlarge and or become inflamed. It's not so much at that point whether there's prostate disease with ED, but whether or not the physiology of the individual is changing. And so I would certainly urge any individual with erectile dysfunction to go see someone who's going to be interested in looking at their testosterone levels and providing them with testosterone therapy rather than giving them a little pill to correct their erectile dysfunction, which might cause their death, but certainly will not help them manage a change in physiology. I'm just appalled by those ads that I see on television, particularly the one that talks about an erection lasting for 4 hours. I mean, if you want to get a male's attention, that little line right there gets us every time. But those are very misleading drugs and dangerous. If you read the package inserts on those drugs, the truth is there, but it's in very small print. There's another question about an individual who has type 2 diabetes and some other concerns, which I will not address. There are specific medical questions, and this is not the forum for me to answer specific medical questions, but I do appreciate the concern you have, Guy, and you mentioned a certain drug that you're taking for your diabetes and that may be causing you side effects. And I can only say that your condition is not a deficiency of that drug. And this is what I tell my patients over and over again when they come and see me and they're on a bunch of drugs, oftentimes antidepressants, for example. And I'll say you're deficient, your condition is not a deficiency of that antidepressant. We have in our culture a tendency to believe that the pharmaceutical industry has, number one, our best interest at heart, and number two, is actually providing us with a safe and effective medication because it got through our FDA. Well, I could go through a list of drugs, and you hear this all the time in the media, drugs that have been approved by the FDA for safety and efficacy, where I found one not to be efficacious and two to be dangerous. So I stay away from pharmaceuticals in my practice unless they're absolutely essential. And there are some pharmaceuticals that are effective for adult onset diabetes if it cannot be controlled by other means. There's some comments here about a great webinar. We certainly appreciate those. I've certainly enjoyed it. That actually takes us through the questions that I have on my list.
Just one comment I'd make about the pharmaceutical industry is that more people died of Vioxx than died in the Vietnam War.
Wow.
And there were 65,000 people that died of the heart condition caused by Vioxx, and as we know, I think it was 50,000 died in the Vietnam War.
Yeah, that's remarkable, isn't it? Yeah, actually, there's a slide that I show in one of my presentations that shows the medical system is the third leading cause of death in this country.
Beyond heart disease and cancer.
Yeah, that's right. And we're not talking about a few thousand deaths. We're talking about hundreds of thousands of deaths in this country related to just the medical model. And it's not all about giving the wrong drug. It's about the drugs that are given, and also, you know, hospitalizations have consequences and risk just going into the hospital. So, yeah, statistics that we're not always made aware of are out there for us to assess. And
I think the thing, Dr. J, is that people really have to be more aware of what's going on around them, both in the disease and in the doctors that they seek for to remedy those.
Mm-hmm. Yeah, our medical model is flawed. There's no question about it. When you look at what we do, where we stand statistically on the money spent on our medical practice, and where we are on longevity and fetal health. I mean, it's appalling how poor our infant survival is in this country. I mean, it's really at the bottom of industrialized nations.
Yeah, it's almost to the level of third world nations in some areas.
That's right. Yeah. Yeah.
Oh, I forgot we are a third world nation. No, I'm sorry.
we may be one. Yeah, we may qualify shortly.
Just to show we have to keep our sense of humor.
Well, Peter, I think you did a marvelous job. I want to thank you for everything you've shown and all the work that you've done, and bringing this. I'm looking forward to seeing the full movie. I've seen your clips a couple of times and have appreciated them.
Yes.
Look forward to the DVD.
Well, thank you. Believe me, I'm looking forward to seeing it as well, because it's been 2.5 years in the making, and it's every time we do something, I mean, we learn something new, and we had to put a stop to it and say, okay, that's enough for this one. Maybe there'll be one after this, but this is enough for this one. You know?
It's kind of like writing a book, isn't it?
Yeah, somewhere you have to stop, you know, and say that's it. We'll continue next year perhaps, but this is all for now. You know?
Right. Well, please let us know when it's out so we can.
Believe me, with your emailing list, you'll be the first to know, and I hope that you'll tell everybody about it and send out emails on our behalf for it. You know?
Sure, absolutely. Well, Dr. J, are you done with the questions?
Yes, I think we've gone through all the questions I have on my list.
Okay. Well, great. Peter, any more things you want to tell us tonight?
Not really. I think I've covered, at least touched on a lot of things. There was one quote that I would like to deal with in terms of diet, and it was something. Johns Hopkins is looked at as being one of the great hospitals in our society, and all of a sudden they've jumped on the whole issue of talking about diet and prostate disease and vitamin D and prostate disease, and yet they continue a high rate of radical prostatectomies and unconventional treatment. But one of the things they came out with recently is their experts, and I'm using that in quotes, now estimate that up to 90% of cancers of the prostate may have a dietary link. Now, up to this, they were saying it was 40%. So very recently, they've now come to say it's 90%. I think that's significant, not only in the way that some people are looking at what we've known for a long time, but the changing tide, should we say, in the way patients want to be treated. They want the truth of the matter, not just something that's skewed for the treatment that makes these people money.
You know, another question has come up. What's the name of your movie, Peter?
It's called, believe it or not, it's quite complicated. It's called Restore Prostate Health Naturally, and it has a subtitle of A Platform for Alternative Treatments for Prostate Cancer.
Very good.
If they go to the website healingartsmedia.net, there's actually a place on there to register, so that when it's finished and we have it available, we will send the people an email saying it is available. And go to healingartsmedia.net. Just all we need is your email address. We don't give it away. It's totally confidential, but we will send you an email when the documentary is complete.
Great, great, excellent. Well, gentlemen, thank you, thank you, thank you. I'm sure this information would be used by several people, lots of people here and around the world. And I think it's really, really important that people know it. Some people just may not have the time to go to seminars and conferences or read books, but just having something they can sit in front of and watch, I think that's invaluable. So thank you both for taking the time to do all this for us.
My pleasure.
Mine also, and thank you for inviting me. It's been a great experience for me. I hope I can do this again.
Absolutely, absolutely. We hope so too. And Dr. J, we really should have you come back and do. You've made a few promises, you know that, right? So.
Okay. Yeah. Well, I generally keep my promises. So, yeah, I'll be glad to come back.
A presentation on cancer in general on the endocrine system, I think, would be a good one, as well as the other ones you've mentioned. Just having people understand what role the endocrine system plays, hormones play in cancer as a whole. I know you've focused on prostate cancer for now, but I'm sure there are some general principles that you can outline for the layperson.
Well, we'll take a look at that.
Okay. All right, folks, this has been great. Thank you. And one of the things I love about technology is that you have people from several different backgrounds coming together. I mean, they have funny accents. Peter is from Coventry in England. I'm from Africa. I grew up in Wales, partially, so I do have some of that accent. And I've been in the United States for about 9 years. And Dr. Mead is up north from Oregon. And Sherry is down in California in the Mojave Desert, and we all have our unique ways of speaking. So this has been great.
you know, David, you know the joke about men from Wales, don't you?
No, I don't. Do I want to know?
Well, Wales is where the men are men and the sheep are nervous.
Golly, what a way to end this.
Hey, I'm signing off, guys. Thanks so much.
Me too.
All right,
thanks,
folks.
guys. We'll talk to you soon.
Thank you. All right, folks. This has been great. Thank you for joining us, and you all have a great evening. God bless.